This one works? Yeah.
You can also ask Shavya.
Yeah, Shavya, why don't you come up? I'm sure they have some questions.
We have the doctor and the patient.
Hello.
Hello.
Yes.
Yeah, sir, a role of, two questions.
Yes.
Role of sacral nerve neurolysis in
Are you
endometriosis, and another is role of Mirena.
Right. Okay. So the Mirena was first introduced as birth control. Okay. Then they tried to use it for abnormal uterine bleeding and adenomyosis. So the role is the same as a suppression therapy. It's progesterone at the end of the day, Mirena. So it works in some women as a suppression technique, but it's an off the label. It's not what the company manufactured it for. So it's an experimental therapy. And can you repeat your first question, please?
The sacral nerve neurolysis intra-op,
Are
where
you
you are
saying-
doing laparoscopy.
are you
So
saying
how
the
far it is?
Pre-sacral neurectomy?
Yes.
Okay. So that is the worst thing to do.
Okay.
Okay. A lot of people do it.
Yeah.
Okay. I personally believe it's the worst thing to do
Okay.
because that is where all your pelvic nerves
Yes.
emerge. They leave that area and form your inferior hypogastric plexuses,
Right.
which innervate bowel, bladder, and sexual function. So, if you start damaging nerves along the way, okay, you are basically taking her symptoms of pain and you are giving her symptoms of urinary dysfunction, bowel dysfunction, and sexual dysfunction. So it's not a worthy trade-off in my opinion.
Okay.
See, I wanted to ask, you said
Yes,
it can be anywhere. What you are doing for other endometriosis?
Yeah.
Brain endometriosis, muscle endometriosis.
Yeah.
What is the avenue for that?
Yeah, so the most, if you're talking about extra pelvic endometriosis,
yes.
the most common, uncommon ones, so to say, are on the diaphragm, okay, on the, in the abdominal wall, so that's called scar endometriosis, or abdominal wall endometriosis. Then there have been case reports of them finding it in the gums, so she bled every month from her mouth, and in the eye and the brain, okay. Fortunately, I have not come across any of those cases, but except diaphragm or abdominal wall. So if it's on the diaphragm, you have to do it with a thoracic surgeon and an anesthetist that's capable of collapsing a lung. So you can do an excision and of that area, and if required, we repair it with a mesh, or if you can do a primary closure with suturing, you can do that as well. And for the abdominal wall, it's the only time we don't use the laparoscopy. We still do the laparoscopy first, and then we remove it via an open incision and then reconstruct.
See, why I wanted to ask is, right, like when you take the history,
Yes.
see, through laparoscopy you can go for pelvic or anywhere in the abdomen you can visualize and you can go. In lungs, okay, if the patient presents with hemoptysis or something,
Yeah.
you can go. See, where you cannot detect the bleed, you know, and the patient has symptoms, something related to headache, or this thing, epilepsy, or pains in the arms
Yes.
and muscles. So, is anything that you have come across that the patients of your like which you got of
So
endometriosis?
I've had patients with symptoms like that, but that doesn't mean the endometriosis is there.
We cannot, how
Yeah.
we can,
So
does MRI, I
if
will
there's,
show you.
you could look at more detailed imaging, but only if you suspect it. I mean, those cases are rare and they have very severe symptoms, right? So they would end up in a different specialty first before the diagnosis is even made that it could be a endometriosis problem. These things are cases that are found retrospectively. After they've gone and removed a mass, the histopathology has shown endometriosis of the brain or something like that. It's not that they reached the diagnosis before.
Okay.
So it was probably a neurosurgeon or someone who excised it and sent it for examination, and
So
this
it
is
was
what
just
came.
brain endometriosis, nothing else,
Yeah,
nowhere else.
Yeah. I mean, even if she did have a history of pelvic endometriosis, they wouldn't have correlated it. It's very difficult to correlate. Yes.
So what is the correlation of menopause with endometriosis? Once menopause occurs, do the pain goes away, symptoms are relieved?
No, it doesn't.
So it's a lifelong condition, right?
It is, unless the disease is removed. It is unlikely to progress because after menopause, the hormones go away, right? But they reduce, they don't disappear. But there have been studies that have shown that endometriosis, certain types also produce their own hormones, which will continue to grow regardless of what you do. So even then, coming back to the logic of removing the ovaries, we are taking away the hormones, whether it's surgical menopause or natural menopause. So why those treatments failed is because you're leaving disease behind. So you're not treating the disease. You're removing things that are feeding the disease to an extent, and the disease is also creating its own fuel for that regard, right? So there are cases that have been, I've personally had them, and they're also documented, that even after menopause, after a hysterectomy, patients have continued pain and symptoms.
Is dysmenorrhea always related to endometriosis?
It's not always related to, but when we look at a differential diagnosis, we always look at dysmenorrhea. Now, when you talk about dysmenorrhea, it's the degree of pain that you're suspecting. So if it's enough to cause a compromise on lifestyle, then I'm very likely to suspect endo. But there are also other factors that it could be adenomyosis, or it could be chronic pelvic pain or pelvic varicosities, or it could be an infection from PID, pelvic inflammatory disease. Yeah. No, the painkillers, like I said, they're suppressing symptoms. So pain is a symptom. Don't look at pain as a bad thing. Pain is your brain telling you that there's something wrong. Now, what you're doing by giving a pill is telling your brain to shut up, right? But that is not the way to treat it, because you're allowing the disease to grow, which is going to progress and cause further symptoms. So your brain is going to, instead of whispering to you, it's going to scream at you till it starts invading further structures, right? So, and there's no pill that doesn't have side effects. So even constantly taking painkillers is causing some damage to the liver and the kidneys. So it's putting a load on vital organs as well, right? So I don't believe in suppression so much. Yes. That's a good question. It can develop anytime, right? It doesn't mean that you have to start from your first period that it's going to be painful. It can develop anytime. I was just showing an average story. There are varied presentations, and of course, even as medical practitioners, we're still learning every day. You see new cases every day. That's not really a higher level of evidence. It's a theory that was proposed. I've not come across a lot of data in support of it for period pain, for dysmenorrhea. There's bony pain and all linked to calcium deficiencies and vitamin D deficiencies. Yeah. No, unfortunately, it's not a lifestyle disease. It's not. Like I say, it's nothing to do with the patient. So the stigma of getting treated, that people will think that there's something wrong with them, is completely mislaid, because you're born with it. It's not something that's acquired. It's not like because you smoke or because you drink or because you put on weight or because you don't exercise. Those are lifestyle diseases. So this has nothing to do with lifestyle. And
I'm a very active person. I barely drink. I've been active my whole life, so and a lot of people actually tell us that you need to exercise more, you're too stressed out, stress less, but it's a part of our lifestyle. We are all stressed out all the time, so I also feel that we should not listen to people who just disregard everything and say it's just your stress or something. So that's something I'm realizing now. I mean, if they're definitely looking into the main cause of the disease and then they're telling you, okay, lose weight, be less stressed, that's a different thing. But I feel like many doctors just tell you you're stressed out. Yeah, thank you.
I have a similar question. Is there urban-rural divide, like you have incidents different in urban area and different in rural areas?
Yeah, that's a very good question. So there's no data on that yet, but from what we've noticed, and this is more my father's experience than mine, because he operates all across the country. So he's saying he sees it a lot more along the coastal belts for some reason. So we need to look into that. So along the western coast and the eastern coast is the highest incidence that he's come across, and severe endometriosis.
Mm-hmm. What percentage of endometriosis is symptomless?
Oh, that's a
Like you say,
question.
1 in 10, so
Yeah.
all 10.
So no. So symptomless means we reach a diagnosis incidentally, okay?
Yeah.
So if a woman has no symptoms, but she has something that she's
Sonography.
undergoing a laparoscopy, or she gets sonography done as a regular checkup and has a cyst, okay? So then she'll come in, and when you put a laparoscope in, you see endometriosis there. So those are symptomless ones, but those are incidental findings. So I would say a very small number are actually asymptomatic. Usually there are some symptoms if you ask enough questions.
Very less number. Okay.
Yes.
So when you investigate for infertility,
Right.
you might come across some symptomless.
Yes, exactly. That's a perfect.
Yeah. So what about adenomyosis? Like, does it get treated by endoscopic surgery?
So adenomyosis is a tricky one. It's so there's no final treatment. The definitive treatment for adenomyosis, because it's in the uterus, is a hysterectomy. Now, of course, there's two types of adenomyosis. There's diffuse, which is like a leak in the wall, and the whole wall is swollen. Or if it forms a localized mass, like an adenomyoma, like a fibroid, but without any borders. Okay, so that is, you can resect that and reconstruct the uterus in a younger woman when we're trying to preserve the uterus. In a diffuse adenomyosis, unfortunately, you cannot treat that surgically. What you can do is just, only for that, in those cases, would you offer suppression.
Okay.
Because if her pain score is 10 out of 10 for endometriosis plus adenomyosis, I would do the laparoscopy to remove all the endometriosis, so her pain score will come down to a 4 or a 5. And then for the adenomyosis, I would have to suppress that. And eventually, unfortunately, I mean, it persists, there's no treatment for it. We are looking at high frequency focused ultrasound treatment to kind of shrink adenomyosis, but I don't believe the credibility of the data that's coming out so far. There are good studies coming out of China. They're one of the largest centers that are doing it. So hopefully we should be able to
Do you
have
need
clear
a
answers.
particular quality of ultrasound machine to
No,
diagnose?
It's not the quality of the machine, it's the quality of the operator. So if you know what to look for, you'll see it. If you don't know what to look for, you won't see it.
Right.
Exactly,
So,
that's it.
but the
Yeah.
normal 3D
So 3D
sonography
is
machines.
not, yeah, 3D is not really needed.
Okay.
It's a 2D machine. 3D, maybe if you wanted to visualize some kind of the cyst. There's 3D MRI now that's coming out that's showing some promise. I don't think it's available in India as yet. But sonography is very operator dependent. So there are sonologists and radiologists all over the world who are experts, who are brilliant at their work. I mean, we've had reports coming in from Australia who have described the disease better than what I can see on laparoscopy. So those are very gifted doctors. So it's very operator dependent. Of course, what they can do sonographically, I can do a fraction of it, but my specialty is in the other part, the surgery.
Okay. So both of you were very good, like it was very informative.
Thank you very much.
I wouldn't have believed that for 7 years it couldn't be diagnosed. It can't be diagnosed. It's hard to believe.
Thank
People remain undiagnosed for more than decades.
Yeah. With the kind of machines we have, people remaining undiagnosed, And have you, last question, have you had people who said, I got better with homeopathy, I got better with Reiki? You know, because we do have.
Yes, of course. I do have patients like that, and very personal friends of mine also said that, I did this, I'm fine. I said, okay, fine.
Because it's very surprising.
It's not something to rule out. I am very open. I mean, even though I am part of the younger generation, I am not only science. I still am open to alternative therapies. There have been, there are lots of patients have advocated that yoga and pelvic floor therapy has helped ease their symptoms. Again, so maybe homeopathy is also doing what suppression does to some extent. So there's no way to diagnose that it's cleared.
No,
right?
but in homeopathy, after a while, they don't continue treatment and they are still all right. I've had one case which was prone to be endometriosis and infertility, and homeopathy treatment, pregnancy and everything okay, like ultrasound prone case.
Yeah, but one case does not evidence make.
With my experience,
Yes.
that is why.
Fair enough. I'm not discounting it, but I'm saying we have levels of evidence in medicine, as I'm sure you all do in yours. So there's randomized control trials, Cochrane reviews, everything that would advise what is the best course.
Thanks.
Yes.
Is homeopathy really meant to?
I think that's a discussion for another forum.
I have a lot of many friends in this field,
Of course.
I know a lot of people in this country that believe anything other than homeopathy.
Yeah, that's true. I mean, there's many these things, right? So there's homeopathy, there's Ayurveda, there's Chinese medicine, there's acupuncture, there's... But I don't think anyone is in a position to qualified in a quantitative way dismiss everything. I mean, you have to have experience in everything to be able to dismiss what works and what doesn't. So if I'm a specialist in Western medicine or allopathic medicine, I kind of just stick to my forte and allow people to practice. I give them the benefit of the doubt. But if a patient comes to me and says, I will say, this is what I can offer you. If something else you've heard about or want to try out, you're free to. But I am not going to take that burden of responsibility on my shoulders. Right?
Sir,
Yes.
one of my friends, she has severe period pains and she has been to about 10 doctors, and it seems her mother also had period pains. So most of the doctors, they say that it is genetic, and because your mother had it, so it's totally fine that you have it now. So is it possible that her mother also had endometriosis and maybe because of genetic reasons she has it too?
Yeah, there is a link between family members. So it is, but that the attitude is a little lackadaisical to say if your mother had it, you have it and it's fine. If your mother had cancer and you possibly have cancer, would you say, okay, that's fine? Right? No, right?
Yes.
So it doesn't make sense to take such a lackadaisical approach to it, because I mean, although it's not a fatal disease, it is a debilitating disease. So you have to treat it. I mean, I don't understand the apathy that's there among some of the medical profession, of course.
Thank you.
That's a good question. So recurrence rates, okay, I didn't want to get into the medical part of it for this talk, but it's good you asked it. So what happens, what we preach is excision, where you cut out the disease. What was taught back in the day was ablation, where you just go and burn the disease. So burning the disease or ablation takes about 30 seconds to do. Excision takes about 2-3 hours, depending on the extent of the disease. Okay, so what happens there is if you ablate or burn the disease, your recurrence rates are anywhere between 50% to 80%. If you do good excision surgery, I'm not saying I'm the best or anything, if you do good excision surgery, the worldwide statistics are below 15%. Okay, not my statistics, the worldwide statistics. Yes. No, because if you've done a good clearance and everything, then you're treating them for fertility, so your fertility potential is the highest. You're not giving them unopposed estrogen, you're giving them things to get ovulation ready, right? So mainly endometriosis grows on estrogen and progesterone to a minor extent, but those are not what is given in fertility treatments to so much. We give different hormones to prepare that. Yes? Yeah. Yes. Yeah, that's what we said, recurrence is possible, but from what we know so far, and we have a long way to go, that excising the disease is the best way to treat it so far. So in theory, if you do a perfect excision, you shouldn't have a recurrence. Excise. Yeah. Yes.
So I went for laparoscopy, diagnostic laparoscopy, where they found there are multiple lesions and there's deep adenomyosis, and then all the pain was put up on the
Sonologist.
fibroid.
Oh.
So it was very big, more than 6 centimeters. That was on the posterior wall. So it was giving me a lot of pressure symptoms and everything. But for 7 years, there was not a single second where I did not have pain. Most of the time I had to take injectables for pain relief. So, I mean, I went to sonologist for to rule out endometriosis, but it was not to be seen on any good news. So, it was a big patch on my right of knee where people said, I am making appendicitis. So, on the appendicitis, so I should go for CT and get the things removed. Then I went for hysterectomy. That time, they found out a big patch on my side. That was cauterized on my side. And for the past more than 4 years, I don't have a single day where I am having pain.
Okay.
Otherwise, it was not related to menstruation. Every day, every moment, I was in
Pain.
pain.
So
it was not picked up on any.
So a couple of things there. You said superficial endometriosis, but when the laparoscopy found adhesions, so adhesions are usually deep endometriosis. It's not superficial. The ones that form scarification and nodules, those are more than 5 millimeters, so those qualify as deep endo. Secondly, fibroids don't cause pain unless they're undergoing degeneration. So it's definitely, so unless there's endometriosis that is causing that pain, your fibroid was kind of an incidental finding, unless it was producing pressure symptoms. Yeah, fine. Fair enough. Thirdly, that the sonologist, okay, you can't see superficial endo. If the pouch, there's no arguing with that. Even nobody can see superficial peritoneal endometriosis. If there's scarification and there's tenderness on the probe during examination, that starts leading to a clue to which area is affected. So when they're doing the sonography and you're reaching a particular area and you're feeling pain there, so then the person should register that, okay, there's a nodule here or there's tenderness here. So I'm going to look for that when I do a laparoscopy. Right?
Pain all over it. It was very difficult to make out that it is because of the probe, because the pain was always there.
Right.
That was not related to the probe.
Yes. No, during the examination, there'll be a different kind of pain. So your pain is a chronic pain, but like an ouch where you withdraw or this thing during an examination would give us a clue. And also, you're saying you had an excision done, so fair enough, you've been pain-free. That's a good, thank you for your share. Yes.
First of all, thank you very much for this very informative session. It was very useful.
It's my pleasure.
Just to add to the person who asked about this Buddhist recur. So if you do a clear excision and it's like pain-free and the endometriosis is gone, do patients need to go through medication continuously or short-term? What is the follow-up after the excision?
Right, that's a very good idea. So we do follow up our patients. We need to do sonographies at 3 months, 6 months and a year. Okay? So to see that there is, just to monitor recurrence. That's personal protocol, it's not worldwide. Regarding medication, that is a very subjective decision to patients. So it's per case. So it depends what I've diagnosed at laparoscopy, what I've done at laparoscopy. if I have an incidental finding of diaphragmatic endometriosis at laparoscopy, and I'm not prepared to do that excision, and by chance if I have to leave it behind when I don't have a thoracic surgeon around, then I would consider suppression. Because if she's not come with symptoms and it's an incidental finding, then you have to leave some behind sometimes, very rarely, but that's what happens. Also in adenomyosis, if she's come to me for fertility and I find I had adenomyosis on ultrasound and or laparoscopy, then I of course have to look at a medical treatment post-surgery. And I have to be very clear with the patient that, you know, I'm not going to take you from 10 to 0, I'll take you from 10 to 5 or 4, and then we'll follow up, we'll go through this journey together and see everything as it comes along the way.
If medical treatment given, is it for lifelong?
No, right, so
How it goes?
you can't give, I think, so the progesterone Visan can't be given for more than 64 weeks now, which is about a year and a half almost.
So what happens? What
There's
happens
only
when you
studies
stop?
showing so far, so we have to stop it. So then once you stop it, the disease grows again.
Okay.
It does not
Because-
treat the disease. If there's a lesion, it's going to stop the lesion from growing, possibly. It might fail also. Okay, so it works in some women, it doesn't work in another cohort of women. But if you take away the suppression, it'll grow. You've not removed it, it'll do its job, it'll grow.
Okay, then you stop for some time and again start suppression therapy, or what is the protocol at present? Because I have seen a girl
Yeah.
who suffered from endometriosis. She was put on suppression therapy. Ultimately, for I think at least 2.5 years she had taken, and she developed osteoporosis. She had a fracture.
Yes.
She was taking
So,
treatment
yes,
for IBS.
that's very good that you brought that up.
And
So-
I don't know now. See, she has not gone for excision. She went for excision, but probably everything was not removed.
Yeah.
You know, and so I like where they stand. She was told you should not get periods anytime.
Oh God. Okay, so like I said, coming back to it, you're putting a young girl into menopause. Secondly, there's many types of suppression. Those birth control pills, which allows them to get their period. You can give only progesterone, which doesn't allow them to get their period. And then there's the injections like Lupride and Zoladex, the GnRH agonists, that group of drugs we're talking about, which were originally invented and put to trial for chemotherapy. Okay, then they said, okay, we'll try it for this. So, and this drug has horrible side effects, okay, and it does about the same efficacy as just giving birth control. So it's suppression, it does not, it's not curative at all, but it causes bone demineralization, bone loss, fractures, early osteoporosis, early menopause, and a host of other symptoms that go with menopause. So it's increasing cardiac disease by taking away the natural hormones of the body. So women get less heart attacks than men because of the estrogen. Estrogen is cardioprotective. You're taking away their natural hormones, so you're suspecting them to heart. They're opening them up to a whole bevy of other diseases. By not even curing a disease, you're suppressing a disease. So the rationale is not logical in my mind.
So at present only 64 weeks it is given, then you have to stop.
You have to stop.
What are the other painkillers which we can give them to, better painkillers which you prefer from your experience in this case?
So it becomes that pain. Okay, so if it's just period pain, then an over-the-counter one will do. But if it's chronic pain, then you have to step up. You have to look at stuff like, you know, if you consider something through a careful examination with a pain specialist, where you start looking at central pain sensitization syndrome. So that is where they have heightened pain. But what endometriosis does is it produces new nerve fibers. So there's very heightened sensitivities to pain. And then you have to go and dull those centers. So you have to give gabapentin or medication like that. That will, but always consult a pain specialist or a chronic pain specialist before you start these treatments.
Okay, thank you.
You're welcome.
Will you or anybody, train Punadadis in doing special therapy for
There's Dr. Mamta Deendayal in Hyderabad. She is a very good sonologist, and she's an infertility specialist. So she has a huge infertility center there, does high volumes, and my father is her laparoscopic surgeon. And she always says that the only reason she learned ultrasound is because if she missed something on ultrasound, my father would stop operating, call her into the theater and say, why did you not diagnose this? So she would go back and start looking very carefully. So that was how she learned, and then now she's got an organization or a society for the Indian Society for Ultrasound and ONG, Obstetrics and Gynae. So they have training courses, and yeah, of course there are very good specialists in India, in Bangalore and in Delhi as well, I think, who are good at endometriosis ultrasound.
There is intraluminal ultrasound. Does that, do you use in gynecology?
We use transvaginal.
Transvaginal.
Okay, so in an unmarried girl, I cannot do a vaginal ultrasound.
No, through the rectum.
Yes, I do through the rectum in an unmarried girl. That's what I was going to say.
Okay.
Yeah.
So
Okay,
that's
because
all.
if you do an abdominal one, you can't see anything. You can't see deep because you have to go through fat, skin, muscle, bladder, uterus, ovaries, and then you can see the. So that's many layers. So when you're in the vagina or rectum, you're at the disease, so you visualize it much better.
Right, but like in esophageal ultrasound, they
Yes.
have a luminal probe.
Yeah.
These probes are not used in.
Not in my experience,
okay.
not in gynecology yet.
Okay.
But
Does she train, Dr. Mamta Deendayal? Does she train others?
no, she doesn't, unfortunately.
Anybody
Yeah,
trains?
there's
Do you
in
train?
Gujarat there's Dr. Sonal Panchal.
Okay.
In Bangalore there's Dr. Mala Sibal, who is excellent. She's very good.
They train?
Yes, they train.
so-
There's an online course that they do, and then you correspond with them, or you can just go to the center and train.
So that's for the diagnosis of endometriosis.
Not only endometriosis, they teach ultrasound. So gynae,
No, ultrasound like
Yeah.
sonologists.
yeah, but they will cover endometriosis in there. So you can always write to them and say, I just want to learn endometriosis ultrasound, and they will be more than happy. They're excellent teachers, and they do perfect,
Okay.
brilliant ultrasounds.
Anything in STEM?
No.
Because we would want that at least one of the sonologists whom we know should be able to diagnose.
Yeah.
uh,
Yeah,
no,
so even I'm not saying by a long shot that my ultrasound is perfect, but I prefer to do my own ultrasound, so at least I know what disease I'm looking for when I do the surgery.
Definitely experience matters.
Yes. So then what happens is, if I have doubts, then I will send it for an MRI,
Okay.
not even for another sonologist opinion.
So MRI can be done even without a doubt. So.
Yeah, but MRI is also interpretation
High,
dependent,
the
right?
high, I know.
So because it's
high
done-
index of suspicion.
Yeah, when you have to look for it. And of course, in our country, cost is a prohibitive factor.
Yeah.
Like in Japan, they used to do an MRI for every patient. Okay, so if I advise an MRI for every patient, it's going to be ridiculous.
Right.
So we'll have a healthcare crisis.
Anything in stem cells research that would matter endometriosis treatment?
Yeah, there's lots of promising work coming out of stem cells, but in endometriosis, there's not a lot of research going on. They're not getting the research dollars. It's going to bigger diseases. So hopefully that'll change along the years. And I think stem cell has a lot of promise. It's in its early stages for all kinds of diseases so far.
America.
But it has potential, that's what. And then even the CRISPR technology, what the Chinese pioneered, where they do modifications on the gene sequences to remove bad genes. So you can have designer DNA, what they call it. So that also has promise in the future. Those technologies still have a long way to go.
Thank you.
You're welcome.
Doctor, I have a question.
Yes.
How do you decide while doing the laparoscopy whether it is the endometriosis has grown for being excised, or it can be possible to sort of let it be through some medication or something? Like when do you decide it has to be excised? At whenever you find it, or
If I can see it,
if you
I'm
can
taking
see
it out. Yeah.
it is to be taken out.
Yes.
Is it? That's the
Yeah.
way forward.
Yeah, very rare ones. If there's a nodule in the diaphragm area, I don't touch that. If it's an incidental finding, if I diagnosed it before, then I've got that team on standby, so then you can address that. But as long as I can see it, I would remove it. That is the best. So your excision is the best. You have to clear as much as you can see.
Okay, doesn't depend on how big it's grown
No, no.
or how big it
Even a
is.
tiny one, you remove it.
It is to be.
Yes.
Because it starts multiplying, no?
Yeah, it spreads, it grows.
It starts growing, yeah.
Anyone has questions?
Yes, ma'am. Sure.
So one thing is that since you mentioned that pain is good and like there are so many side effects to painkillers, so should we avoid them, like deal with the pain?
No, of course not. I'm just saying chronically don't take painkillers. Okay? I mean, you know in America there's an opioid crisis because they give them very strong painkillers for everything. Okay? Fortunately, we don't have that problem in India so far. Okay? Because we don't throw pain medication at everything and we give the dumbed down over the counter painkillers. So there they gave oxycodone or whatever, which were morphine derivatives. So those are very strong painkillers. So they have a high dependency also. Okay? So if you see in some of the older generation in India, among the chronic pain patients, not endometriosis, all kinds of chronic pain, arthritis, etc., they take a Restil. Okay? You may have seen a lot of them take a sedative to go to sleep at night. So it's some kind of dependency is there. I mean, those are benzodiazepines and they have some dependency. They also cause sluggishness in the day. So as far as over-the-counter pain medication, fine. Once in a month for mild cramps, acceptable. A lifelong of painkillers is not something I would recommend or wish upon my patients.
Yeah, and you mentioned about that, like we should listen to our body, like we should be aware, and so much of research is available. So, what are the sources that we should trust? Like, if I'm Googling about some symptoms in my body, then what sources on Google should I trust?
So, since you all are in a research institute, I would say if you have access to PubMed or any of those, Google Scholar is the lowest of this thing, but it's still better than Google. So all of those. Then Nancy's Nook is a great resource. I mean, they're all curated levels of evidence from articles which are actually being published by experts in the field. And, you know, the same principle, what we're trying to do with ICE is along that model. Of course, they have a vast library of data and we are in our infancy, so it's a long way to go. But you have to be very careful with what you read. I mean, there's good information and there's bad information out there, so.
And as a gynecologist, could you suggest some good birth control measures?
Okay, we can talk about that afterwards if it's relevant to the topic. Okay, so pain is subjective. If it's discomfort, okay, it could be normal, it could be nothing. But if it's pain that's causing severe pain, then that might be symptomatic of something. You should always get it checked out. Yes, ma'am.
Yeah, once or twice a month, Meftal, is it okay to take Meftal spas?
Sure. Yeah, it's okay.
Because my daughter,
Yeah.
she has all these symptoms,
Hmm.
muscle cramps and everything, and she's okay with Meftal. And sonography so far has been normal.
Okay.
So what other tests
Yeah.
do you recommend?
Okay, so if I was talking in black and white, by definition, any period pain that requires medication or rest should be considered pathology until proven otherwise. Okay, but of course there are gray areas. People have different thresholds for pain. So if it's mild pain and she needs the pain Meftal spas and it's suppressed. Yeah, no. So I can't do a diagnosis like that. But if I sat and I spoke to the patient and got into the details of how bad the pain is, what she can tolerate, what she can't tolerate, how it affects her mood, mindset, school or work, whatever she does, activity, social life, then you can kind of get an idea on how to proceed with it. Right? Yes.
Yeah, one last question. Yeah.
Adenomyoma. Okay. Okay. So again, it becomes very tailored to what you want. If you, I don't know how old you are, and I'm not brave enough to guess. Okay, so if you want a hysterectomy, that's an option. If you want the Mirena, that's an option. But the Mirena will stay in and may or may not work for up to 5 years. After that, it's got to come out, and then you would probably need that hysterectomy. So the Mirena is a temporary delay of that hysterectomy if needed. If you're symptomatic and your adenomyoma is causing you problems, then those are the treatment options available. Those are the two options available. Yes.
Thank you. Is there any other question? Yeah, please.
I mean, it could be. I would have to talk to the patient in more detail. These are questions that are difficult to answer in the third person that get a little lost in translation. So. Yeah. Yeah. Yeah, so see, if you look at the checklist of the symptoms and if you're answering yes to a couple of them, then you should definitely consult your gynecologist and say, okay, I suspect this, what do I do now? Right, so that's how to take it forward.
My second question is that, if this endometriosis is related to seasonal changes, my doctor is something that pain is more in summer, during summer period. Related to that seasonal change.
No, not that I'm aware of.
Because one of our doctors, who doctor has prescribed suddenly Meftal.
Yes.
He has complained. He has prescribed daily 2 or 3 tablets as per your complaint.
Right.
Another experienced doctor, he overlook it and say, do exercise, go to school by walking and all.
Sure.
Sit at one place. And if pain will be there in that person, that's it.
Yeah, so
How these two opinions from
exactly. So you have a living, breathing example of 10 opinions that have, until if it's obviously if it's causing a problem and you're not getting the right treatment, you're going to keep looking for a solution. So unfortunately, that's the way the thing goes now.
nowadays is PCOD and
So PCO and endometriosis have a very strong link. Yes, there is 70% of PCO have endo and endo have PCO. So there's a very strong correlation between the two. Yeah, it's the worst thing to give them. You're putting a teenager into menopause, is basically what that injection is doing. Okay, you're giving her hot flashes, night sweats, insomnia, fatigue, irritability, bone loss, and danger to the heart. So that is the worst thing to give a teenager. I think it's almost criminal. No, I mean, of course, I deal with them. I'm a doctor. I have pharmaceutical companies who come and say, this is our drug, these are our studies. And then if you read that this doctor has gotten funded so much by this study, obviously he'll write whatever they want. Okay? I mean, even giving the doctor the benefits of the doubt that, okay, it's true, they did it for a small cohort, but those are very selective studies and those are low levels of evidence. Okay? There's a lot of bias coming in. If somebody is presenting a study saying this is doing this, and you have to take it with a pinch of salt. So there's an international society of endometriosis surgeons who meet, and we go through this every year of what is working, what doesn't work, what, are false treatments. And so you have to update yourself also as a physician when you treat patients, because endometriosis patients are the most well-researched patients who come to you. So when they sit down across you, you better know your stuff, because they will ask you questions that you have better read upon.
Thank you.
You're welcome. Thank you.
So if there are no more questions, we'll end the session. And at the end, I would like to thank once again Dr. Abhishek Mangeshikar for coming over here to IIT campus and bringing about this awareness on endometriosis and other related things, answering so many questions very clearly. So it was a very illuminating talk that he gave, very interesting talk also, even to non-medical people like some of us. And with this, we'd like to take it forward, maybe form a support group for endometriosis on our campus. So maybe those who are interested can
I'm sure you've got a very capable candidate.
Shravya is here, and
Yes.
Dr. Abhishek also
Of course.
can guide us. I request him to
Sure,
guide us
sure.
further.
I'd be happy
And thank you very much.
Thank you.
So those who are interested, please talk to Shravya. We'll form a support group for endometriosis patients and maybe other related problems
Okay.
also. I wouldn't know that. So once again, it's my great pleasure to give a small token of appreciation, very small token
No,
of
no, no, no,
appreciation.
no. I honestly, I truly had a wonderful time, and I really appreciated the interaction and the questions. And I always encourage questions. There's no such thing as a bad question or a silly question. So please ask, and you can catch me afterwards also. I'll be happy to answer your questions. Okay, and thank you. It was a real pleasure for me to be here.
Very small, very small. So please join us for tea, and if you have any further questions, we can take them offline also. Thank you very much. Thank you. Thank you very much.